Shafi, John, thank you so much for joining me here for a short discussion here at WHX Tech. You just had a debate on the World X stage where you agreed and disagreed. So Shafi, you mentioned that it was already announced more than a decade ago that we will not need radiologists due to AI, and that assumption or that prediction was wrong. And John, you said that prediction was actually right. So let's start by elaborating that. So is AI replacing doctors, or is AI not replacing doctors? Is AI not replacing doctors just yet? So where do we stand on that?
Be careful.
So I think we will understand the conclusion, and I'll give it straight away, that AI will augment doctors in the future. It's about replacing. The question that we posed in the discussion that John and I had was around Geoffrey Hinton, who is the godfather of AI, who made this prediction in 2016, saying that we should stop training radiologists because within 5 years, they'll essentially be replaced. That's where this whole term came from. Because radiology was one area. There's image analysis, which is ripe for AI intervention and diagnostics. What we now see is actually an increase in radiologists, actually more numbers coming through. In fact, I spoke in Singapore last week to a crowd full of radiologists. They weren't getting any less over the course of the last 5 to 10 years. So the question is, did that kind of thought from Geoffrey Hinton, was it not prescient enough? Was he not thinking about the bigger challenges in healthcare? Was it simplifying it too much? Probably. He now agrees in 2025, actually what he's referring to was image analysis being disrupted, not radiologists. So he's corrected himself to a certain extent. But I spent time with radiologists, and what's evident from their discussion why radiology hasn't completely been disrupted or AI platforms haven't been scaled enough is threefold. One is original algorithms for AI analysis, chest x-rays, CTs, MRIs, had to hit 95% sensitivity for FDA approval. But that was on a data set they were using. They weren't then exploring for another data set which might not be as accurate. And they reproduce it on another data set, they sometimes hit 70-75%, which would not meet FDA requirements. That's one problem. Secondly, most of these image analysis were looking at one dimension. Has this patient on chest x-ray got pneumonia? Has this patient got pneumothorax? So their one dimension was, whereas radiologists look at the whole picture, bones, lungs, etc. The third thing that will change them, I think, going forward is LLMs. Their algorithms are almost obsolete because LLM technology coming in is now much better than their algorithms already. They've redesigned their platforms. So that's why it hasn't scaled as much as it should do. And John?
That was a long answer.
Yeah.
Let me give you the short answer. Yes, they'll be replaced.
Yeah.
We need to get radiologists out of the dark rooms and have them get a little sun. I think it'd be better for them and for medicine in general.
Why do you think that?
Wait,
Where does
one thing. Shafi's son and daughter are going to be physicians. Would you recommend either of them become radiologists?
They have no intention of being
but
radiologists.
If they wanted to, would you be a staunch advocate to become a radiologist?
I think radiology, what will happen is that there'll be more interventional.
That's changing the, yeah, sure. More interventional radiologists.
Sure.
I'm sorry, I interrupted you rudely.
So why do you think that the prediction was right, just the trajectory was wrong?
I think that if you look at the trajectory of AI, of technology in medicine, and just the large language models, which is pattern recognition, it's extraordinarily fast. Look just in 2-3 years how the world has changed. If you extrapolate that sort of exponential or hyper-exponential curve, it's undeniable to see that radiologists, at least from a image detecting perspective, will become shifted. You know, I don't see it. That's a soft endpoint, the humanity, the totality of the patient. I don't know. I think that's different in a way.
Shafi, a question for you. So yes, definitely in the last 2 years with large language models, everybody's using them. However, when it comes to clinical decision support, it's very challenging because if you want to have a solution approved, then it needs to work on edge cases, and that's difficult, especially with generative AI, where you don't get to same inputs, so you could validate your solution. So how do you see that the clinical practice is changing by the use of generative AI outside the clinically approved norms? Patients are using AI, doctors are using AI.
Sure.
So how is that already changing care, even outside regulation?
Yeah, that's a really good question. So some parts of the world require less regulation. The EU is the most regulated part of AI at the moment. But if you go to the US, actually, there's much more bandwidth for innovation without as much regulation, for example, and also other parts of the world. So we are already using AI in part of our clinical processes. You've heard of ambient AI. So a lot of people are now using ambient AI to capture a conversation, to then formulate it into a document, to send it to electronic health record. So AI is being used already to allow you to be more efficient with your time. Rather than typing out letters, etc., it does it automatically for you. We've seen that agents, agentic AI, being used to certain circumstances to help you formulate a diagnosis. What you can't do at the moment is let the AI make autonomous decisions. That's really the holy grail of AI. There's one company actually called Skin Analytics in the UK who were gained Class 2 EU approval to allow the AI, which was a computer vision image platform on a phone, look at skin lesions to predict whether it's cancer or not cancer, for example. And the EU now has given approval for that to be allowed to be used autonomously without clinical oversight. And that's really important. At what point do we get to that we can rely on something without clinical oversight? I don't think society is ready. I don't think medicine is ready to allow that kind of deregulated pathway, if you like, to allow AI to make decisions, make diagnosis. It's all very supportive. Mm-hmm. And that is something that we have to challenge going forward.
Yeah. One question that kind of opens up in this space is related, on the one hand, to autonomy, on the second hand, to the fact that people are using AI, even if it's not regulated. And in mental health, for example, we're starting to see examples and articles where OpenAI is getting sued by a mother of a child that made suicide while also using ChatGPT. There's another example of a mother who wrote an op-ed for the New York Times describing how they, after her daughter made suicide, they basically went through her ChatGPT discussions and saw how ChatGPT was used as a therapist. Did well to some degree, but the question that I'm getting to is this discussion around how much do we trust AI compared to people that has been addressed for over 10 years, and this expectation that AI needs to be 100% accurate and that doctors can make mistakes. And I think as a society we've never made the decision to allow a percentage that's not 100% for AI or technology to be accurate. So how do you see this challenge? The fact that maybe we are expecting too much of technology and are avoiding using it just because it's not 100%.
Well, I think that we have to understand that AI is not human cognition. And we always strive to make it think more and more and more like a human, but it's not a human. It thinks differently. It creates this subdomain of coherence. It predicts the next word. It looks at a cluster of language to solve the problem. So they are extraordinarily inexact. They're very, very fragile in a way. You throw a strange word at a large language model, like a cat sleeps 12 hours a day as part of a prompt, and it gets confused. So these models are extraordinarily fragile. That being said, the fragility of the human system has to be compared too. Let's talk about an SSRI. What is the role of SSRIs in suicidal ideology in children? It's actually in the label. But how much are we talking about that if we're talking about suicide in the social context? I think the questions are just coming to the surface, and we don't even know the question. Voltaire said, "Don't judge a person by their answers, judge a person by their questions." And I think we have to begin to fundamentally understand what is the nature of truth for an LLM? Does truth even exist in this context? I don't think it does. I think it's quite different. So is it an unaided tool? Maybe not. Maybe it'll ultimately evolve to become something that we partner with, that we use as a supplement to our cognitive behavior, because I don't want to give away my mind.
Yeah.
My mind is mine. It's what makes me me. And if we defer thinking to the machine, the clinical outcome is less important than our loss of self and our loss of individuality. So it's like, it becomes more philosophical almost than clinical.
Yeah. We're going to go back to that, but Shafi, your clinical perspective on the expectation of 100% accuracy.
So first of all, nothing is 100% accurate. That's the first thing. But I think we hold AI to a higher standard than we hold clinicians. That's the problem. Clinicians make mistakes. We only have a certain amount of knowledge and experience. And as a cancer surgeon, for example, for 30 years, my domain knowledge is very specific. It's a small vertical. When I qualified in medicine, I had a breadth of knowledge: obstetrics, gynecology, psychiatry, pediatrics, etc., etc. As I got more and more senior, I became much more narrow. And that's my expertise. Whereas AI has the breadth constantly, which we don't have. And therefore, it's much better at diagnosing rare diseases. Because rare disease means you have to understand a lot more about healthcare and potential diagnosis. So actually, one of the advantages of LLMs is putting in rare kind of symptoms that people struggle to diagnose. Honestly, it comes out with a much better differential than a human being would. So in some ways, it's better. Some ways it's limited. And the other things that we talked about earlier, me and John, were the two human elements that make a doctor. And they're good and bad things. One is intuition, that gut feeling that you get when you look at somebody, say, I know what's going on. And secondly, it's the judgment. And what is judgment? Does AI have judgment? Does it have intuition? And that's a question that we've been asking for a long time. And I think John's got some ideas about that.
You know, if you want AI to be as smart as a doctor, you have to let it be as bad as a doctor, because it's a dual-edged sword. The imperfection of the human system, when mirrored by AI, does have an intrinsic imperfection in it. Now you said that intuition, right? And that what people usually say after intuition is the art and science of medicine. It's a science, but it's also an art. It's a certain subjectivity that I have using my intuition, my human gut response. That's utter nonsense. Let's discard with that and move on. It is a hedge.
You don't think there's that. No, I disagree, John. I disagree. I'll tell you what I disagree with. For example, when I'm on the ward, seeing patients, for example, with acute abdominal pathology, it's kind of my specialty. I go around, look at somebody, and within a second say, yes, that person is sick, or that person needs an operation.
But that's not magic. You're looking at the way they sit, the way they breathe, and the way they act. Those are completely quantifiable clinical dynamics. You know, what you're hiding behind is the magic of the art of medicine. All the art of medicine is an excuse to fail. Because when the therapy doesn't go that way, well, it's the art. Sometimes we fail. Where's that dynamic in the concept of a large language model?
I'm gonna put a patient hat here,
okay,
and just share.
I agree with Shafi, by the way.
I'll share a joke. I'm a colorectal surgeon.
Yes.
Do you know what makes a good colorectal surgeon? It's a gut feeling and a sense of humour. I thought I'd share that with you while we're having some fun.
But we can quantify gut.
Yeah. So, patient hat,
yes,
and the challenge that I
yes,
have with clinical decision support and AI-based things. So, the thing is, so when you have the doctor making the decision and standing behind the decision, whether it's intuition-based, whether it's data-based, you have someone that you can ask how that decision was made and why that decision was made in that way. What I find troubling is the examples of basically poor use of healthcare for clinical decision support coming from the US, where basically for example, for rehabilitation, clinicians at insurance companies are told that they need to say based on the algorithm how many days the clinician, the patient needs.
Right.
And then if that time is actually wrong, patients don't really have anyone to turn to basically dispute that decision, because even with the insurance company, like nobody's gonna take the responsibility for that decision. So it's this untangible decision maker that
Are you talking about accountability here?
yes,
And
accountability that can result in basically patients being even more lost in the system because there's no direct person that they can discuss their wrong diagnosis or
Sounds
their
like a job
challenges.
for AI.
Yeah.
I think so. No, I think one of the things that I think one of the bigger questions is, where does the accountability lie? John often talks about the driverless cars. We talk about AI, autonomous driving, mistakes being made, who's liable. The question is going forward is, when you're deploying AI for clinical diagnostics or treatment, for example, and there's a mistake or errors which will be made, who's liable? Is it the AI? Is it the hospital that's deploying the AI at the clinic? Is the clinician, for example? Those are questions that have been unanswered just yet because we've been so slow and methodical to deploy this in a safe manner with the regulations, which is probably quite right to do that. But at some point it will come, and that conversation will change about where the accountability is. At the moment, the accountability for any patient problem lies with the attending or the consultant, and I am responsible for the entire patient care, for example, and my name's at the top of the patient bed. So everyone knows there's a route of accountability, and the person in charge will be that accountable. That is unclear how we do that going forward, and I'd love to get John's thoughts on that.
Is the problem one of obfuscation or of communication? In other words, are the issues misunderstood and miscommunicated? And does that cause this rat's nest of problems? Or are companies saying, don't you give the right answer, give them the wrong answer? Is it, how do we kind of clear that up a little bit? Because I think that oftentimes when a patient asks an insurance provider for prior authorization, that conversation is very simplistic, not technologically rich, certainly not clinically rich, and they get lost in the language. It becomes a problem of communication. I think that's a wonderful opportunity for large language models to cohere and come together. It's interoperability from a linguistic perspective. I argue that the most interesting conversations will not be between doctor and doctor, patient and doctor, patient and patient. It's going to be between LLM and LLM.
That's probably already happening because if insurance companies use LLMs to decline claims and then patients try to use LLMs to dispute those claims.
But the LLMs actually talk with one another. They actually use a sort of gibberish communication tool where they don't even use text or speech.
That's right.
They use a hyper communication that almost sounds like the old-fashioned dial-up modems.
That's right.
And they talk to one another. So I think some of those problems are not bad medicine or even bad insurance coverage. I think they're very, very sloppy in poor communication, so that I don't understand what prior authorization is as a patient. I don't know the difference between biopsy and pathology. So I think that there's an opportunity to do better there. I don't think that insurance companies are always as malevolent as people make them out to be. They certainly chase the dollar when we probably should be chasing the outcome. But I think that there's a lot of opportunity to see the problem more clearly before we try to come up with an answer.
John, at the end of the debate that you guys had on stage, you said that AI is not intelligent. Is that? Yeah. What did you mean by that? Tell me.
Okay, this gets tricky now, right? I'm even going to hold the mic for this one. What does an apple look like to a large language model? When you and I look at an apple, we see it in 3 dimensions, 3 spatial dimensions. We may talk about it in terms of time, the 4th dimension, but in fact, large language models have no sense of time. They're atemporal. Now, don't think too hard about that because it's confusing, but they have no sense of time. They do everything at once. All their calculations happen in a functional instant. Okay, that's number 1 weird. Number 2 weird is when you take this apple and you put it into the LLM, a frontier model like ChatGPT-5, it takes that word, makes it into a thing, right? It tokenizes it and it pushes up into the model. It looks at that apple in 12,288 dimensions. Now, again, don't even try to figure it out. Just think with me. 3 dimensions, I get it. 4 dimensions, maybe 5 dimensions? I have no idea what that means. How about 11 dimensions? String theory is in 11 dimensions. Inconceivable to the human mind. Don't get it. Large language models think that way. They think in something called a hyperdimensional reality. And that it is fundamentally different. It's antithetical. That's another way of thinking about it. It's antithetical to human thought. So it lives in different quadrants of cognition. And I'm going to be talking a lot about that tomorrow, but basically, it doesn't think like we do. It's not better.
Yeah.
It's not worse. It's different. And we
So
have
how
to
does
recognize
that translate to the impact on healthcare?
Well, I think that we have to recognize that what large language models do is they look for linguistic cohesion, coherence. They look for the way words organize. And sometimes that's not always the right answer. There is a finesse to the human system. So it makes a difference because we have to recognize that AI is not getting more and more and more and more human-like. Mm-hmm. It may be doing a series of sequential tricks to simulate human thinking. It becomes asymptotic, if you will. Yeah. But these large language models don't think like humans, and we don't think like humans. We don't think like AI. Yeah. We think in time. We have a level of emotion. We have all sorts of, the richness of humanity is what makes us different.
Well, thank you both for this brief discussion, and I will definitely continue it in the upcoming years.
Thank you. We'd be lost without you. You really bring such a wealth, a depth of knowledge and communication. So thank you.
Thank you.
All the very best. Thanks, Sasha.